Good afternoon, everybody. It's a really great pleasure and honor for me to be a part of this non-cardiac CMEs, because being a cardiac anesthesiologist, we are given the liberty and pleasure to have the default environments where we have the excellent cardiac output monitors with us. But in fact, the challenges are with the non-cardiac anesthesiologists who deal with so much complicated cases with suboptimal monitoring what they require many of the times. Now, so we are going to talk on enhancing the recovery after the surgery. What does it mean? Like, in general, it means that we have to make patients much better after the surgery. Like, approaching the patient in a way that we manage patients right from the admission to the discharge in a way that we increases the chances of survival, reduces the chances of morbidity, and we let them patients to go early at home. So it was purely developed by the Kellet and in Denmark in 1990s, late 90s, and gradually it was initially for open colorectal surgeries, then laterally implemented into the laparoscopic surgeries. Basically, it is about from the admissions. It starts from the time of admissions to the pre-counseling, pre-admission counseling. It leads to the bowel preparations, then the tubes, drainage tubes, NG tubes. Then it's go up to the level of the epidural analgesias, then adequate and optimal fluid managements with the maintenance of the fluid electrolyte balances, intraoperative warming up therapies, routine mobilization and care of the patients, early mobilizations of patients, and patients with the gut stimulating agents, as well as early oral intake to the patients. And ultimately, the perioperative oral nutrition should be restarted, and that complete package should be managed in a way that these patients go early home without any complications. So enhancing all these procedures requires a very strategical insight. Like there has to be ideal patient counseling. Many of the time, patients are advised carbohydrate drinks, and the reason behind this carbohydrate drinks is that it reduces the chance of the insulin resistance. The bowel preparation is not required unless patient been operated for the left side of colon surgeries, and patient should be admitted usually in the day of a surgery rather than admitting quite early. Of course, perioperative analgesia has been nicely explained, and patients definite incisions. Of course, it's discretion to the surgeons, but there has to be lesser the incisions, more minimal invasive is always giving better. But the most important thing has been given, and support has been given to the limited intraoperative fluid therapy. So it has been shown in the literature that much higher amount of the volume given to the patients can lead to the intraoperative a lot of complications. But I would little change into it. Rather than from the limited intraoperative, I would just consider it's a targeted intraoperative. So whatever we give, what is more to the patients, what is less to the patient has to be decided with some goal what we decide intraoperatively as the patient's need. That's what we are going to discuss today. After surgery also plays a very important role. Like most of the anesthesiologists in the private practice, after the surgery, they just say, my job is done. But nowadays, the trend is changing. Now the anesthesiologists are taking care of the patients right from the surgery, even till the discharge, and even the intensive care unit. So the pre and perioperative management, the CCSU of as soon as the closing of the IV fluids, arrival to the ward, the patients, early mobilizations and high protein drinkings is recommended. Even the day pass it on, the patients should be even having the epidural analgesias can go discharge with from the ICU to the ward. Patient should establish early GI functions, and they can, if you feel that the patient is happily eating and drinking and passing the flatus, considering that patient has adequate bowel movements, and that is the time where we consider that patient is discharged. So complete package has to be managed in a way that enhances the recovery. So to improve outcome after the surgery in critical ill patients, something which is known as the goal-directed therapy or hemodynamic optimizations or pre-optimization if we implement these standards right before the operations. So how to manage patients in peri-operative management, and that's something which is one of the important predictors for the outcome, like over-zealous, over-hydrated patients, over-hypervolumic patients as well as hypovolumic patients can lead to the lot of complications. And one of the important publications, which is very well known and every one of us must have gone through these articles, that the hypovolumic or overloaded patients can lead to the edema and organ dysfunctions. And hypovolumic can lead to the hypoperfusion. So we have to keep the patient somewhere in the optimal range. Now to decide what is an optimal range for the patients, and that depends upon the patient's condition, patient's cardiac conditions, for which patient is even operated for the non-cardiac surgical problems. So many things has to be considered when we decide to keep the patient into the optimal zone. Now, that is sometimes very difficult unless we are having the monitors, the tools, which is available nowadays to every hospitals, which is less invasive, and that is something which can be useful very effectively. Now, there are good study published that the length of the stay or the total cost or the post-op complications or morbidity is much, much high if the patient is falling in the hypovolumic or hypervolumic conditions. So ultimately, all the literatures are suggesting us to keep the patient or pushing the patient in the range, in the zone of the optimal conditions. Sometimes without any adequate peri-operative monitoring standards, we sometimes say that, okay, patient has fallen with the mean arterial pressures, with the cardiac output, so then we should start giving the volume. But in fact, the deterioration starts much, much before the falling of the cardiac output and mean arterial pressures. And then we sometimes realize that patient has gone into the sinus tachycardia and hypotension, and that is almost, in fact, the time is lost. The time, in fact, starts at the level of much before, that is about only 10% of the blood loss start compromising the patients. And the earliest, like previously we used to use the gastric tonometry, and that monitor detected us that the earliest compromise, hemodynamic compromise happened to the first organ is the gastric GI gastrointestinal mucosa. Because a little evidence of the hypoperfusion and hypoxemia can lead to a lot of GI problems that breaks the barrier of the gastrointestinal intestinal mucosa that leads to the translocation of organisms. So adequate adequate perfusions and cardiac output management is very important, and just by clinical evaluations of the mean arterial pressures and blood loss, we may be a little late than routine. Routinely, we manage these kind of patients with the blood pressures, heart rate, CVP. At the most, we look at the volume status, and we sometimes, if we don't look much of them, then we just keep our mindset with the restrictive approach. So, why are we talking about the peri-operative optimization of hemodynamics? Because ultimately, we are not here to just look at the cosmetic value of a monitors by looking at the pressure 110 by 70 and patient is okay. We want to look at how much delivery of oxygen patient is getting by our hemodynamic standards, and then we can go it by VO2 or DO, that is oxygen consumptions and delivery of oxygen indices. Of course, we don't have the non-cardiac anesthesiologist has lot to do in the surgery than just doing all this stuff. So it is not easy for them to just calculate each and every with the formulas and find out which is the ideal oxygenation for these patients. So then the normal value of delivery of oxygen is about 500 to 6 ml per minute square, and the ratio of these two numbers is what is known as oxygen extraction ratio, and we do not need to spend so much time because nowadays we have a lot of non-invasive monitors available with us which does this for us. So to keep the patient in all these optimal zone, there are the PGDT, perioperative goal-directed therapy parameters of hemodynamics optimization are available, which measure the stroke volume variations, delivery of oxygens, and central venous oxygen saturations. And these as a whole in a one single management protocol can definitely take up to the as close as the optimal level, optimal standard of the patients. There are n numbers of articles which has shown nearly 30 to 60% of a reduction in post-surgical complications if we take our patients with the perioperative protocol-based goal-directed therapies. And the articles, there are a lot of n numbers of articles which are RCTs and meta-analyses has shown that if you target the goal for customized for the patient specific, then definitely we can take the patient as closest the physiology. Now, how to do about that? That's important. Now, the goal-directed reduces complications in every form, like we talk about the acute kidney injury, GI complications, surgical site infections, urinary tract infections, lung infections, and so forth, so more. The reasons why, because we are in a process of optimizing hemodynamics. In other way, we can say that we can make the patient with an adequate cardiac output. There is not a real number like 3 liters or 4 liters or 7 liters is a normal cardiac output. It is either adequate or inadequate. So we can approach the patient's need according to the requirements. So one of the studies which published in one of the leading hospitals has shown that they could reduce their morbidity in major abdominal surgery with nearly 60%. And what they did it with the stroke volume variations approach. And that's what we have as small monitors available, standalone monitors. And we need to put a just arterial line, and nowadays every anesthesiologists are well versed with putting the cannulation into the radial artery, and they can monitor the high risk cases. And that stroke volume variation approach, that gives a corrected idea that whether the patient's heart is in the Frank Sterling phase or not, whether heart will be responding to the volume or whether we give the volume and cardiac output will be increased or not, provided patient is on controlled ventilations and the patient has got a optimal tidal volume settings. So stroke volume variation approach is really considered to be one of the best in reducing the problems with the inadequate cardiac output. In one of the studies with the spinal anesthesia of total hip arthroplasty, what they did it, how they approach the goal direction is by looking at first they look after the mean arterial pressure if it is more than 65 or less than 65. If it is less than 65, they had given the 250 ml of the colloid solutions, and still if it is maintaining less than 65, then then again they give a bolus of 250 ml of the colloids. So first aim, their aim was to maintain the mean arterial pressure to 65, and if it is not maintaining adequate mean arterial pressures, then they used to give with the ephedrine 10 milligram boluses. The ideal other protocol which is in control of all aspects, like the maintaining saturations of more than 95%, hemoglobin more than 8 gram percentage, the heart rate less than 100, and mean arterial pressures more than 60. Like considering every single aspects, the oxygen delivery, we found that, and that what they managed as ideal achieving the maximum stroke volume and maximum target of delivery of oxygen. How would they maintain the maximum stroke volume? As I said, they used a cardiac output monitor, which is less invasive in the arterial pressure monitor, like say a flow track or other monitor, where they set up the stroke volume, and says the patient has got 40 ml of stroke volume, they give the 250 ml, and if the stroke volume is increasing more than 10%, then again they give the second boluses till the time where there is no further increase in the stroke volume more than 10%. Say the 40, the next time they say the 44, then they keep on giving still the volume where the hemodynamics or the delta stroke volume, that is the stroke volume increase should not be more than 10%, then they stop the volume supplementation. If everything is fine, and then what they look at the oxygen delivery. And then they have to give the ideal adequate oxygen delivery, they have used inodilators or something to increase the oxygen supplementations. If patient has got low hemoglobin, they used to give the PCVs to increases the oxygen carrying capacities. So basically, like in early good direct therapies, what we used to do it in a sepsis patient or emergency department, and which was under controversies later on, where they said the mean arterial pressure, CVP, as well as the mixed venous. Here also they suggested to maintain the first mean arterial pressures if it is okay, and still patient has got not adequate cardiac output, we can just add the dobutamine just to maintain it. So here the aim was to see the change in the 10%, more than 10% of the stroke volume, to see that whether the post-operative complications. So what they found that that if you utilize your cardiac output knowledge by knowing the stroke volume as well as the ideal hemodynamics by giving the volume of maintaining the mean arterial pressures both together, looking to that, combined to them, it means that the patient has been achieved with the adequate of the hemodynamic data. Achieve the goal, what their protocol was to achieve the goal with the maximum stroke volume possible. That's by giving the boluses of the volume. So, another study recently published in 2015, the perioperative goal-directed therapy and post-operative outcome in patient undergoing high-risk abdominal surgeries, and they selected all the ASA grade 2 plus abdominal surgery patients, and what they have found that they have looked for the length of stay into the ICU, in the hospital, the extubations, the kidney injuries, neurocognitive dysfunctions, the stroke, myocardial infarctions, sepsis, every aspect they see that. And what they found that whether no implementation of the goal-directed therapy used or with the implementation of the goal-directed therapy, ultimately post-implementation goal-directed therapy has much more earlier hospital discharge as compared to the without or no implementations of the goal-directed therapy. One of the articles published in Cochin, India, they have had the two groups. In one of the groups, they had the mean pressure of more than 65 millimeter mercury, central venous pressure more than 8, and adequate urine output they consider more than 0.5 ml per kg, and the oxygen saturation more than 70. These are the same protocol what we used for emergency department for early goal-directed therapies. And in group B, they've included the cardiac indices as well as oxygen extraction ratio. Now, by adding the cardiac indices, one of the important advantage what we can get by looking at the cardiac output, that if we have the central venous line, central cannulations, we can have the CVP. If we have the cardiac output, then we can measure the systemic vascular resistance, SVR. So, if we have the cardiac output and mean arterial pressures, we can easily measure that mean arterial pressure minus our right atrial pressures divided by cardiac output, that is a systemic vascular resistance. If your patient is falling in the normal systemic vascular resistance, you can just keep and get away with only giving the volumes. But if your SVR is low, you can add on the vasopressors, or if your SVR is very high, you can add on the dobutamines, kind of the inodilators. So if you have the cardiac output along with your other parameters, then definitely you can maintain the SVR very well, and that maintaining the SVR can definitely increases the tissue perfusion and chances of survival. Now, recently there are a lot of advancements happened, even the enhancement recovery after the surgery society has been formed in 2010. Even the guidelines has formed by the NHS Trust UK. So many associations and international bodies have joined into the movement to go with the guidelines and protocols based on enhanced recovery after the after surgery. So many British consensus guidelines has been published. Even different surgery has published, like abdominal surgery, thoracic surgery, neurosurgery, with their enhancement of recovery. So that can be the custom made. So the National Institute of Health and Clinical Excellence has shown the suggestions that you can manage your patients with targeting the cardiac output rather than only mean arterial pressure, that if your stroke volume is increasing by 10%, keep on giving the volume. If it stops increasing the stroke volume by more than 10%, then you can just wait and watch. If you have a cardiac output, you have the CVP, you can measure the SVR, and then you can add the vasopressors or inotropes according to that. And with this, the NICE guidelines, it was based on so many meta-analysis they did. On all the meta-analysis, they found that it favors the protocol-based. Even the complication is much lesser in the goal-directed therapy group. Just only 2 slides. The readmission admission percentage was much lesser in the goal-directed therapies. The mortality is much less in experimental goal-directed therapies. And what they found that even in the pediatric age group of patients, when they compared with the enhancing protocols with the routine standard protocols, and they just look at the length of stay, which they consider the 3 days to 1 day, and what they found that after the 30 days follow-up, with 60 patients included into the analysis, what they found that Here, important aspect to be seen that all the goal-directed therapy has been validated for more than ASA grade 2. Not lesser than that, may not be necessary in the routine patients. And in all those categories, they found that ERAS is possible and safe. It enhances recovery, it's cost-effective, and it is not just for the colorectal surgery, but it is for the all kind of non-cardiac surgery as well. So take-home message is we have burnt our fingers in emergency and critical care department when we used to talk goal-directed therapies. Since 2011, it has remained in the controversies. But intraoperative, the intraoperative data are much better than there. Should we apply ERAS to all? At moment of time, it is mainly applied for the more than ASA grade 2. So in probability, definitely in those cases only you will put a radial artery and cardiac output monitors. Flexibility is always there, so you can customize your protocol according to the surgeon and institutions you have. And most important thing is there has to be a standard protocol for managing difficult cases to maintain patient-specific targets. So it has to be a patient-specific target. We do not say that you keep on flushing 250 ml for IV patients, or you just look at the stroke volume. Along with that, in a high-risk candidate, you should always look for the SVR, PVR if possible, or mixed venous oxygen saturations. If not possible, take just venous samples from the internal jugular vein and take a blood gas and see whether your hemoglobin and SCVO2 is matching your requirements or not. So just the last point is to promote enhancing recovery after surgery protocol concept. There has to be a multimodality approach, right from the admissions to the discharge. It is not only intraoperative, so just manage the patient as your own patients, not that you manage the patient only in the intraoperative period. Thank you very much for the kind listening to me.